Predicted and observed mortality at 10 years in patients with bifurcation lesion in the syntax trial. This is a predefined sub-analysis. The present study is a predefined subgroup analysis of the syntax study, which was an investigational driven extended 10 years follow-up of the syntax trial. For the purpose of the present analysis, patients were categorized in 4 groups: PCI with at least one bifurcation on the diagnostic angiogram, PCI without bifurcation, CABG group with at least one bifurcation on the diagnostic angiogram, and CABG group without bifurcation. Of course, the baseline characteristics are different. Patients with bifurcation are 2.5 years older than without bifurcation, and their Euro score is higher, 3.9 versus 3.4. The ratio 3 vessel disease left main are different, with more isolated left main of left main with 1 vessel disease in patient without bifurcation versus more patient with 3 vessel disease in patient with bifurcation. The syntax score is higher by 10 points. Low syntax score is prevalent in the group without bifurcation, and the high syntax score is more prevalent with bifurcation. The number of stent and the total stent length is higher with bifurcation, whereas in surgery, off-pump was more frequent in patients without bifurcation. Where are these bifurcations located? In the distal left main in 27%, and 6% of the ostial and left main shaft has also at least one bifurcation in the distal bed of the 3-vessel disease. In patients with 3-vessel disease, 33% has 1 bifurcation, 26% 2 bifurcation, and 8% 3 of more than 3 bifurcation. Death, stroke, or MI at 5 years, patients with bifurcation are depicted by a solid line, and patients without bifurcation by a dashed line. The worst outcome is in patients with bifurcation, 21.9%. The Kaplan-Meier curve of CABG with and without bifurcation are superimposed with a rate of 17.2%, and the best outcome is for CABG without bifurcation with a rate of 13%. As far as revascularization at 5 years is concerned, the worst rate is 26.7% for PCI with bifurcation. This rate is significantly different from the 19.4%, which is the rate without bifurcation, and the rate of revascularization of CABG with or without bifurcation are 14.6% and 11.5% respectively, and are not significantly different from each other according to log rank. The next slide shows the hazard ratios for clinical outcome, CABG versus PCI in patients with 3-vessel disease and bifurcation, and in patients with left main and bifurcation. All the hazard ratio are adjusted considering the numerous confounding factor in the baseline characteristic. In 3-vessel disease, all the hazard ratios are in favor of surgery. Death, stroke, MI at 5 years, 0.72, revascularization at 5 years, 0.38, death at 5 and 10 years, 0.65 and 0.61. 28.8% of death in PCI versus 19.7% with CABG. In distal left main, there was only a difference in revascularization at 5 years and no difference in all-cause mortality at 10 years, 31% for surgery and 29.1% for PCI. The next slide shows all-cause death at 10 years, bifurcation in red versus non-bifurcation in blue. Surprise, surprise, the winner with the lowest mortality, 19.8%, is the PCI group without bifurcation. The worst outcome, the solid red line with a mortality of 30.1%, is for the PCI group with at least one bifurcation, which is significantly very different from the PCI group without bifurcation that had a mortality of 19.8%. Then we have the two CABG group, the one with bifurcation, the one without bifurcation. Both have an identical rate of mortality of 23%. That makes sense. Graft bypass that type of bifurcated lesion. Now, the key question, based on the average treatment effect, should you send all your patients with bifurcation to surgery? The answer is, of course, not. Today, we have decision tool to move from average treatment effect to individualized prognosis. In the randomized population of a trial, there are individuals in green who expect to derive benefit from the novel treatment, others in blue who have an equivocal response, and those in red who will be harmed by the novel treatment. In clinical trial, the average treatment effect result in a kind of multicolor patient which express the mixed average effect of the different treatment response of each individual in the trial. It is nowadays essential to identify this individual with an heterogeneous response and segregate the patient population based on treatment response. The syntax score 2020 was redeveloped to predict 5 and 10 years mortality and 5 years MACE in the Syntaxis trial and was externally validated in the Freedom, Best, Pre-Combat, and Excel trials. There are two effect modifiers, the anatomical syntax score and the type of disease, 3 vessel disease and left main, and 7 prognostic factors, age, diabetes, creatinine clearance, ejection fraction, current smoker, peripheral vascular disease, and chronic obstructive pulmonary disease. The probability of 10 years mortality can be calculated with the formula at the bottom of the slide. If you intend to treat the patient with CABG, use the formula with the blue parameters related to CABG. If you intend to treat the patient with PCI, you use the formula with the red parameter related to PCI. This slide deals with the individual predicted mortality versus the observed mortality at 10 years in patients with bifurcation. The parameter of the syntax score 2020 are tabulated for case 1 and case 2. For case 1, there is an absolute risk difference in mortality at 10 years of 2.1%, 7.8 for PCI, and 5.6 for CABG, very acceptable. There is in case 1, quasi-equipoise of PCI and CABG for all-cause mortality, and you will, of course, select PCI. In case 2, the difference in mortality is 12.9% in favor of CABG. CABG is better. PCI is not acceptable. The $1,000 question is, how many cases with equipoise or PCI better than CABG are there in the bifurcation group and are to be identified? The difference in mortality at an individual level is considered as a treatment benefit in survival of CABG over PCI, of vice versa, of PCI over CABG. All the predicted and observed treatment benefit have been regrouped in 4 quartiles. In the first quartile in green, the predicted treatment benefit is in favor of PCI, and indeed the observed death difference is in favor of PCI, as depicted by the Kaplan-Meier curves in the first quartile, with a higher mortality after CABG in blue. In the second quartile, there is a perfect equipoise in mortality with Kaplan-Meier curves superimposed. In the third and fourth quartile, the predicted and observed treatment benefit is in favor of CABG, and the Kaplan-Meier curve shows a significant higher mortality after PCI. The good news is that 50% of the patient with bifurcation may nevertheless be treated with PCI according to the prediction of the syntax score 2020. In conclusion, presence of bifurcation lesion is a warning signal in the decision-making process of the heart team, since PCI in this subset of patients was associated with a significantly higher all-cause death at 10 years compared to PCI. However, this overall bad prognosis could be possibly mitigated and even overruled by the individual probabilistic analysis provided by the syntax score 2020. Thank you very much.